I have a comment and then a question for Dr. Eriksson. So in the foot and ankle, you're dealing with fairly small areas. And what we found, we used to mesh everything, and oftentimes the area between the area of the mesh where there was no skin would then heal by secondary intention. We'd have irregular surfaces. And that was problematic in the foot with shoeing. Sometimes you get some fungating areas. So we've gone to doing non-mesh full skin graft with some percutaneous perforations to get rid of the fluid. And and I think that gives you a better long-term result in shoes, et cetera, than meshing. So that's why I would have reservations about your technique for the foot. I think for large areas, it's spectacular. The one area where I thought it might be very useful is in donor sites, which are most problematic to heal. And you could always have an extra little piece of skin from your harvest to repopulate the donor site. And I wonder what your thoughts are.
Thank you. Regarding your first comment, I don't really have an answer because we don't have enough experience to be able to state how, first of all, how well the depth of the wound fills in, number one, and number two, how durable a walking surface would be created. So that remains work in progress. There may be a small benefit to the fact that the surface tends to be more even than with conventional skin grafting. Regarding your second comment, I agree.
Dr. Najafi.
Excellent talks. I have a general question to the panel. We know that we are dealing more and more with older population, and in other surgical disciplines, it's recommended that if we use a surgical intervention, it's better to evaluate that whether our patient is frail or not. I'm just wondering that whether there is this kind of the guideline for lower extremity surgery to ensure that if you have an elderly subject, whether this subject is frail or not, and whether this kind of the surgical intervention it's suitable for that patient or not?
Well, you know, we're interested in this. So that there are frailty indexes that have been derived for, I think the Hopkins group has the one that's used most frequently to try to figure out two things. What can your patient tolerate as far as a procedure? But the second thing is some of those frailty indices predict survival at 1 and 2 years. So in our patient population, at least in our practice, we see increasingly elderly patients with limb problems, and so the question always is, we look at the patient first. So what can you get them through perioperatively, and then how much are you going to go for someone that has a limited life expectancy? And we don't really have an actual frailty index that's been validated for vascular patients yet, but I think that'd be really useful because it's not just getting them through the procedure, because with really good care, we can get even frail people through the procedure. It's the recovery time, and then how much benefit are they going to get out of it if they're sort of the end of their life cycle. So I think that's a really important question, but we have the eyeball test, but everybody's eyeballs are different. What do you guys do, John? I talked to Chris yesterday, and you have an increasing population of extremely frail patients who've failed multiple things, and they get sent to you.
Yeah, I can't help but think also about several patients that come to mind from the past couple weeks of 5 trips to the OR, 6 trips to the OR, and someone who fits into that frail category, and how many times are we going to expose them to anesthetic, sometimes requiring general anesthetic, although we do most under sedation with a block. I recall a recent purely sedation case last week, and I remarked to the anesthesiologist, I said, wow, the blood pressure seems low, and this looks like a challenging patient. I assume you want me to get this done quickly. Is 25 minutes good enough? And he said 24 would be better. So there are situations where I think we do sometimes push it too far, but then again, if we're not willing to take the risk with this patient population, then we probably wouldn't be saving any limbs on any patients. So these are high risk, they're frail patients, and I think we have to do our best at continuing to screen for risk, but we're certainly very aggressive in getting these folks to the operating room, even in high-risk categories.
Sir, thank you for patiently waiting.
Hi, it's Perry Meyer. This is for Dr. Mills. In Canada, our problem really is getting, is getting timely access to vascular support for reconstruction. But now what my biggest problem is knowing in advance what it is that I want. And so my question is there, or are you, I mean, you know what you're doing, but being able to translate that to, again, stupid people like me, in a way that I can utilize that information and know when I make my referral to the vascular surgeon to indicate that I kind of know what I want, and not to dictate what they should do, but to kind of give them a little bit of a push to say, let's say, we talk about angiosomes, not surprisingly, not very many vascular surgeons are using the angiosomes theory. So when I ask for, some kind of, let's say, anterior tib support, some anterior tib flow, they just ignore that and kind of do whatever they can do, so to speak, which is useless unless they're directing the flow to where I need it. The reconstruction, if it's just a reconstruction to do it for the procedure purpose, it doesn't suit my purposes. So I'm wondering whether or not there is any efforts to kind of translate this into, not for dummies kind of way, but to translate what you do into a simpler form where we can use that information to dictate or kind of to guide our referrals a bit more accurately and a bit more intelligently.
Yeah, I'm not quite sure I'd answer that. I mean, so when you try to get a team together, there's different teams that work. So in Georgetown, the team is driven by plastic surgery and podiatry. In our place, it's toe and flow, it's podiatry and vascular. I don't know that you should try to dictate what the specialist does, but when you build your team has to be able to provide all the possible therapies that patient might need. So in some settings, there may be someone with a really high level of endovascular expertise and somebody else with open surgical expertise. Those could be two different people. They could be the same person if it's a dedicated limb salvage case. And I think ideally you'd want that patient to get reviewed by all the people that could offer therapy to that patient, and then you figure out what's best for that patient. And so the problem that you're alluding to, I think, is that specialists tend to do what they know how to do. So if you get referred to Dr. X is really good at procedure Y, so every time Dr. X gets a patient, he does procedure Y, whether that's the best procedure for the patient or not. And that's a huge problem. And if you look at variation in care in this country, certain operations are done way more frequently in some places than others. In the same community. I mean, in lots of communities, what diabetic foot care a patient gets totally depends on who sees them first and what their little system's like. There aren't really good standards, and I think that the answer to that is to try to build teams. That's it.
I would expand on that a little more also in agreeing with you, Dr. Mills, but the problem we have is a lot of all of these new tools and new things that come out are all industry driven. And unfortunately, in our realm, they're still looking at the silly endpoints of patency and does this tend to this or does that balloon do that, or we've moved away from what the reality of what we need to know is, and is there adequate perfusion into what part. So I think partly it is we have no idea. We have no data and adequate data-driven standards that should tell vascular surgeons exactly what the guideline to do what is and how much. Do you have to open one vessel? Do you have to open two vessels? Do you have to open three vessels? Because, I mean, cardiologists have 1, 2, 3 vessel disease in their standards, right? So you could actually hold them up to that. And, this is what I need for this patient. We don't have that. Are we working on that? Heck yeah. Do we need to find that? Yes. Do we need to do more data and come up with more ideas? Yeah, because I personally don't know what the answer is.
But with an angiosome theory is a similar kind of approach to cardiac catheterization, where they're looking to perfuse a particular part of the heart muscle, and so presumably we're trying to perfuse a particular part of the foot.
Not to angiosome theory is promising, but there's some flaws in it. It's not. The heart is simpler than the extremity. I mean, you can perfuse. We did bypasses for years where we bypassed to whatever was open. We looked at the angiogram, we picked the best vessel or what we could reach with a vein conduit. And there are subsets of patients in whom wound doesn't heal or takes longer to heal. But amazingly, a lot of those patients, what we found with Indesign and Green is you can't always predict anatomically what you see on the angiogram with the amount of perfusion you're going to get. Now, if we have a choice, like the case Christian showed, the patient had a heel wound. Well, that patient could have had a bypass to the dorsalis pedis or the posterior tibial. But we did this for years. If you could get blood flow easily with an open bypass to the place where the wound was, we did that. We didn't really know what angiosomes were, but we kind of used common sense. But we still don't know. I think there's subsets of patients where angiosomes is critically important, and there's others where it really doesn't matter.
Dr. Gibbons?
Well, I have one question, but just to further comment on that, we know we spent $240 billion on diabetes in 2010. The greatest proportion of that was on treatment of peripheral arterial disease. So we can say, and to that last question, you know, how do we arm up for the best reperfusion? But we better do it fast because CMS isn't going to continue to allow us to fire stent after stent after stent, then hopefully do a bypass and then do something else. Because there's a cost crunch with all of this. So we need to pay attention to that. My question is, with the upside down, downside up, endo revascularization, we know that diabetes is a tremendous inflammatory vascular disease affecting every artery. So my concern is that when you're doing all of this in an endovascular manner, how are you protecting against the inflammatory consequences of what you're doing?
So I would say there's multiple things you have to take care of. One is it starts with technique. So we know that barotrauma is related also to the amount of intimal hyperplasia and inflammation that you're going to have in the wall. So having really slow inflation times is going to affect the amount of inflammation localized. So that's a technical point. Number two is we know more and more data coming from Europe and from Latin America where there's non-FDA approved devices that have drugs coating and that actually diminishes the amount of inflammation and hence the movement from quiescent cells into intimal hyperplasia. And then now we're moving forward to getting more drugs that can potentially affect that, like xylostazol, et cetera. So I think there are different fronts. I would love to give you that specific answer. I think there's multiple things we could do, but certainly it's something we need to take care of.
Sir?
I have a much more mundane and simple question. I'm an orthopedic surgeon. One thing we always talk about in our meetings is what's the post-op course? What do we do after we do our surgery? This is directed to you, Dr. Eriksson, on your skin grafting, and you said keep it moist. What type of dressing do you use? How do you keep it moist? When do you change it? When do you let them weight bear? Those types of things.
Thank you. Those are good questions. First, you need an interface dressing because you don't want to disrupt the grafts for about a week. And that interface could be a number of things. There are a number of brand names, Interface, Adaptic, Zeroform, probably just about anything will work. Then we recommend using a hydrogel on top of that, and then a foam dressing with relatively low water vapor transmission rate.
Okay. And when you start getting a successful healing and some integrity of your graft, when do you let them put a shoe on? When do you let them walk on it? When do you let them use it? How long does it take for that to mature before you have a stable foot that you can stress?
Most of this is done on an ambulatory basis outside of the OR, and we encourage them to walk on it immediately, but to keep the leg elevated most of the time in between short walking trips, and if it's in the area of a joint, to immobilize that joint in a walking booth or a knee immobilizer.
Thank you.
Our last question for the session.
Hi, Luigi Ochoa, Roma. I would like add some comments on PTAs. We have a huge experience on this method to limb salvage. And we found that it's very important, a strict collaboration between the the diabetologist, diabetologist who take care of the wounds, and the interventional radiologist who makes the PTAs, because we have to decide what kind of artery we need to heal our ulcer. So we follow very much the criteria of the wound-related artery to heal the ulcer. Then we have a strict follow-up of those patients with TCPO2, and so we are able to record before and after the PTA the level of TCPO2, and sometimes we require an additional PTA if the TCPO2 does not rise after PTA.
Any comments from the panel?
I would comment that, we happen at Georgetown to be lucky and unique in having a plastic surgeon help drive our service through Dr. Addinger, but in most cases, plastic surgery is not that interested in wounds. But we have rapidly learned and certainly practiced the method of Dr. Mills and Dr. Armstrong. Of the base unit of this has to be tied into whatever you're doing in limb salvage, has to be direct communication with the vascular specialist. So we certainly advocate that as the baseline of this has to be someone who's taking care of the wound and someone who's taking care of the blood flow, whatever specialties those may be.
All right, well, thank you so much to all of our panelists.